Hi, my name is Victoria Chen, and today I'm going to talk to you about anemia among refugees. The reason that I chose anemia was because I suffer from iron deficiency anemia, and I have two children who have the sickle cell trait. The reason I wanted to talk about the refugee population was because I just finished doing a project on refugees, and one of the common problems that they have is anemia. So what is anemia? Anemia is when blood does not carry enough oxygen to the rest of the body. The three main causes are Number 1, blood loss. Number 2, lack of red blood cell production. Number 3, high rates of red blood cell destruction. To the right, we see a picture of a non-anemic person with a normal amount of red blood cells, and then an anemic person and the anemic amount of red blood cells. Anemia is diagnosed with a physical exam and a blood test. These are some symptoms of anemia. The global prevalence of anemia for the general population is 24.8%. As you can see on the map, the highest prevalence is found in Africa. That's followed by Asia, the Eastern Mediterranean, the Western Pacific region, the European region, and the Americas. The prevalence of anemia among refugees in 2015 is not exactly known, since the state refugee health coordinators do not conduct surveys annually. However, from 2004 to 2010, the anemia prevalence in refugee camps was greater than 40%. Refugees are generally at high risk for anemia due to displacement and food insecurity, and as you can see on the map, most refugees come from the continents of Africa and Asia, which is where the highest prevalence of anemia is found. The definition of a refugee is an individual who, owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group or political opinion, is outside the country of his nationality and is unable to, or owing to such fear, is unwilling to avail himself of the protection of that country. Now I'm going to speak about a few of the determinants of anemia. Iron deficiency is the most common cause of anemia and what is normally associated with the term. However, as you will see throughout this presentation, it is not the only cause. The body needs iron to make hemoglobin, and hemoglobin is what carries oxygen from the lungs to the rest of the body. In the 2010 Global Burden of Disease Report, iron deficiency anemia was ranked as the third leading cause of disability globally. A study done among refugee children here in Georgia, entering DeKalb County, showed that refugee adolescents had a prevalence of iron deficiency anemia 2.5 times higher than their U.S. counterparts. Refugee children under 5 showed a prevalence 1.5 to 5 times higher than U.S. counterparts. Diet may also be a determinant of anemia. In certain parts of the world, they eat certain foods which may not be high in ferrous iron. They also consume certain spices, certain breads or grains, which may block iron absorption. A study done on rats administered different doses of thyme, which is a spice that they use, found that rats that were given over 2 teaspoons of the herb developed anemia caused by insufficient iron and vitamin B intake. These are the diets of many refugee populations. Socioeconomic status may also lead to iron deficiency anemia. Research from the Korea National Health and Nutrition Examination Survey showed girls with higher income had lower anemia prevalence. It also showed anemia tends to decrease as household income increases. One of the reasons may be people with a higher socioeconomic status consume more iron and are able to afford vitamins. Food insecurity may also be a factor. 4 studies conducted in the U.S. have linked anemia among infants, children, and adolescents to food insecurity. One of the leading causes is diet, since evidence suggests food insecurity can result in low food and nutrient intake. Diets in food insecure households tend to be lower in iron and other nutrients and higher in carbohydrates and fats. A study done on African women showed their mean daily intake of calories to be only 1,434. According to WHO guidelines, a non-pregnant woman weighing about 130 pounds with a low level of activity should consume at least 1,984 calories a day. Refugees generally have low socioeconomic status and high food insecurity. Pregnancy may also lead to iron deficiency anemia. It's a global problem, but it occurs in up to 61% of pregnant women in developing countries, which is where most refugees come from. Inherited conditions may also cause anemia. Hemorrhagic telangiectasia is a rare genetic disorder which causes frequent nosebleeds, and the chronic blood loss may result in iron deficiency anemia. Thalassemias are a group of disorders where there's a decrease in either the alpha or beta globin chain, and it decreases the production of red blood cells. Folate malabsorption is also a rare disorder which results in folate deficiency. If it's left untreated, it causes megaloblastic anemia. G6PD is a genetic disorder most common in males. It affects the red blood cells and can cause hemolytic anemia. And sickle cell anemia results when a child is born with 2 sickle cell genes, one from each parent. The cells are shaped like a sickle instead of being round like normal blood cells. The sickle cells do not last as long as the normal blood cells, which is what leads to the anemia. According to the CDC, inherited hematologic disorders are common among refugee populations, and they're most common in places with a high prevalence of malaria because these disorders provide a defense against the disease. Certain diseases may also cause anemia. Malaria is one of those. It's most commonly carried by a mosquito. It leads to anemia by causing impaired intestinal iron absorption and impaired iron release from hepatocytes, which leads to iron deficiency anemia. In a study done among pediatric patients, children between 13 and 36 months were most at risk due to poor immunity of the disease. Schistosomiasis is another disease which can cause anemia. It is carried by a parasite found inside a certain type of freshwater snail. The anemia in schistosomiasis can come from 4 different conditions: an iron deficiency due to blood loss, the spleen not working correctly, the autoimmune response to the breaking down of the red blood cells, and inflammatory anemia. These are both parasitic diseases which occur mainly in poor tropical and subtropical areas of the world where many refugees come from. Poor sanitation increases the risks of contracting the diseases. The highest prevalence of these diseases are found in Africa. HIV is another disease which may cause anemia, and it is actually the most common blood disease found in HIV patients. It's been documented that up to 95% of HIV patients are anemic, and the most common forms are iron deficiency anemia and anemia of inflammation. There was a study done on adults in Nigeria which found those patients had anemia of inflammation, and then another study done on children found that their anemia was due to iron deficiency. Most of the refugee population with HIV is due to unprotected sex with an infected partner. There's an idea that exists that in conflict-affected populations there are more sexual risk-taking behaviors. This would place refugees at an increased risk of acquiring the disease. Lead in the blood may also be tied to iron deficiency anemia because it interferes with the normal formation of hemoglobin. A study conducted in Pakistan tested lead in the blood and hair of children. The blood lead concentrations were significantly higher in children with iron deficiency anemia. The study concurred with a prior study which found infants with iron deficiency anemia had higher blood lead concentration than infants without anemia. According to WHO, the highest blood lead levels are found in low-income countries, especially those that have mines or where they still use leaded gasoline. Leaded gasoline is still used in the Middle East, so that may affect refugees from that area. This is my web of causation conceptual model, which shows the determinants linked to anemia as well as to each other. For example, the socioeconomic status of a refugee can affect their environment. Their environment may have lead in it. They may also have parasitic diseases, and these parasitic diseases may lead to inherited conditions, and HIV may be an inherited condition. On the other side, socioeconomic status can lead to food insecurity, which may lead to a diet poor in nutrients, which may lead to iron deficiency, and pregnancy may also lead to iron deficiency. As far as the social work perspective is concerned, most of the time social workers don't deal with the problem of anemia. Those are healthcare workers. However, studies have shown behavioral and social-emotional differences of children with iron deficiency anemia. Infants with iron deficiency anemia have been observed to be more wary, hesitant, fearful, withdrawn, shy, unhappy, tense, less playful, and show less pleasure in reaction to stimuli. If left untreated, these infants tend to show increases in anxiety, depression, social problems, and feelings of detachment in adolescence. A study conducted with an iron supplement and a non-added iron group of infants assessed 10 years later found more adaptive behavior among the children given iron as infants. According to the study, iron supplementation of infants with iron deficiency anemia, or IDA, was associated with improved school performance, mental health, and personal relationships at age 10. Therefore, perhaps social workers should consider the possible behaviors of refugees or other populations that are diagnosed with IDA. For community-based responses, I found the Iron Like Turkey community-based program. This program works with infants 4 to 23 months. It includes free iron supplementation to all children under 1 year and provisional iron treatment for all 4 to 24-month-old children diagnosed with iron deficiency anemia. The goal is to prevent anemia and improve the nutritional status of infants. There are 5 major components: advocacy, support for effective training, support for effective counseling, a public education program, and free supplementation or iron medication to infants 4 to 12 months. The supplementation use in this project is 68.8%, and the prevalence of anemia is now down to 7.3%. Therefore, for now, the program seems to be achieving its goal. As far as health-related policies are concerned, a current and controversial policy is the mandatory NCAA sickle cell trait screening program. I have mixed feelings about this policy because, as I mentioned earlier, I have 2 children with the sickle cell trait and they both play sports. This policy resulted from a legal settlement when a football player collapsed and later died from acute exertional rhabdomyolysis, which is a complication of the sickle cell trait I never knew existed. This policy targets student athletes with sickle cell trait. The goals of the policy are to screen athletes for the trait so the necessary precautions can be taken. This policy has been tested. A policy analysis was conducted to estimate the number of athletes with the trait and the anticipated number of exercise-related deaths caused by the trait among NCAA student athletes. Here are the policy analysis results. It was estimated the policy would identify over 2,000 athletes with sickle cell trait among a 4-year cohort of student athletes. If the intervention proves to be 100% effective, screening could prevent the deaths of 7 student athletes over a 10-year period. There are costs associated with the testing, and there is also potential for discrimination towards athletes identified with the trait. Furthermore, even if the athlete and staff know the player has the trait, there is no guarantee they will comply with the guidelines. Some coaches just choose to ignore them. In order for this screening policy to be successful, the NCAA needs to have an intervention plan as well. When refugees come to the United States, they're permanent residents and able to attend schools and universities. If they become involved in athletics, this policy may affect them. So in conclusion, what have we learned? Well, we've learned that anemia is when blood does not carry oxygen to the rest of the body, which may be caused by several different factors. We've learned refugees have a greater chance of becoming anemic due to certain circumstances. We learned anemia may affect behavior, which has implications for social workers working with refugees or other anemic populations. We learned that community programs primarily target infants and pregnant women in hopes of preventing anemia. And we've learned that policies for certain forms of anemia may lead to discrimination of certain populations. These are my references. And this is the end of my presentation. I hope you enjoyed it.